And I don't see the chat, so I just take a look if anyone wrote anything. Okay, no. And okay, cool. So let's start. Just a few words about myself. I'm going to give you I'm gonna hold some of your seminars, not all of them. I'm a third-year resident in radiology. I'm interested in neuroradiology. My name is Andrea Hoyrat. I did my first year of radiology in the United States, and I just returned to Hungary a year ago. So if anyone is interested in like the system over there, you can ask some questions about this as well. Otherwise, let's start. So I'm going to talk about neuroradiology. And first slide. So what you need to know that this semester we updated the radiology curriculum and the requirements for the exam based on the European Society of Radiology requirements. And you can see this list here, what you need to know for the exam on this slide. I'm going to upload the slides later so you can review them. And we also created a list of images that you need to recognize for the exam. So this is the list of each pictures you need to recognize for the exam. And we are going to go through all of these during this seminar. So you need to know brain and spine anatomy on MR and CT scans. You need to know the circle of Willis, the vessels, like you need to name them. You need to recognize the following MRI sequences: T1 weighted sequences, T2 weighted sequences, FLAIR and DWI, like diffusion weighted imaging. Then, in the case of ischemic stroke, if they show you a CT scan with an area of stroke, you need to know which large vessel is occluded. Then you need to know about perfusion-diffusion mismatch and the penumbra. Then you need to differentiate between these 4 types of hemorrhages, in the brain hemorrhages: epidural, subdural, subarachnoidal, and parenchymal. You need to recognize spinal cord compression on CT and MR scans, and you need to recognize an aneurysm. Probably they're going to show you like a big one, not like a small one. Okay, just a second, because I need to also download the attendance list, so I'm just doing it now. I hope everybody's here by now. Okay, I guess it worked. So what are we going to discuss? So first, we're going to talk about basic concepts in neuroradiology, about methods, CT and MRI. What's the difference between them? When do you need to order each of them? We're going to discuss the MRI sequences that you need to recognize for the exam. Then we're going to talk about anatomy a little bit. And so we're going to discuss some pathologies like hemorrhages, stroke, and some other pathologies. And then we're going to talk about the spinal cord. And among the pathologies, among all these topics for the exam, these are the most important. So probably you're going to have questions about these topics. Okay, so let's start with some basic concepts. And one of the most important is left and right in radiology. So, so it's always the same. Like in radiology, the right side is on your left-hand side, and the left side is on your right-hand side. So you have to imagine that the patient is facing you, and you're just facing a patient. So on an X-ray, can you see my mouse moving? Actually, because I'm not sure if you can see this. Yes? I didn't hear you, but I hope you can see me. So, and the left side is on the other side. And in a chest X-ray, the way you can know this anyway is that the heart is, of course, on your left side, and you're not going to trick you on the exam. So you need to know left and right for the exam. And this is the same with cross-sectional imaging with like a CT or MRI scan. You can imagine that the patient, you're looking at the patient from below, and then this is the right side, this is the left side. Okay. Then the next topic is planes, imaging planes. So you need to know the name of the imaging planes. And this is a little bit different what you learned in anatomy. So this is on the first image, this is a T2 weighted MR scan, and this is an axial plane. And this was called transversal in anatomy, but in radiology we call it axial. In the middle, this is the sagittal plane. This is a sagittal T1 weighted MR image. And the third one is a coronal plane. And this one was called frontal during anatomy lessons, but in radiology, we talk about coronal, like we call it coronal. And here on the right corner, you can see how these planes are acquired. Okay, so that's the difference. What's the difference between CT and MR scan? How can we differentiate these pictures just by looking at them? Because you need to tell which one is a CT and which one is an MR when it's not, like there is no label. So the most obvious difference is that the bone is really bright on a CT scan. So it's really white because the density is really high. So here, this white thing is bone, and that's a CT scan. The other big difference, like in MR, the bone is like dark, or you can't really see them that well. The other big difference in the CT scan is that the spatial resolution is not that good. So when you see this granular pattern here in the brain parenchyma, that's probably a CT scan. An MR scan can look in different ways depending on the sequence that was used. Probably the T1 weighted MR sequence is the most similar to a CT scan, but yeah, there are different kinds of sequences, as you will see soon. In an T1 weighted MR sequence, the ventricles are dark, and on the CT as well. And on the T1 weighted MR sequence, the gray matter is gray and the white matter is white, like in normally. And on the other hand, on the CT, the gray matter is lighter than the white matter here. And then, yeah, that's the major difference. What are the other differences between these two modalities? So CT works with X-ray. It's kind of like a three-dimensional X-ray, and a native CT brain equivalent dose is 2 millisieverts, so it equals 8 months of background radiation. On the other hand, MRI doesn't use ionizing radiation. So if on your exam someone asks you which one comes with more radiation, CT or MR, that's a tricky question because MR doesn't come with radiation. There is no radiation with MR, no ionizing radiation. So that works. The MR is a big magnet, and it works with electromagnetic waves, not with ionizing radiation. On CT, we talk about density, and on MR, we call this intensity. So density, so in CT, we call things hyperdense, hypodense. On MR, we call them hyperintense, hypointense. The CT has lower resolution, but it's much more faster. A CT scan takes few minutes. And MR has higher spatial resolution, but it takes longer time, depending on the protocol. Brain MR can take like 10, 20 minutes or even longer, depending on how many sequences are we acquiring. Okay. Next concept is contrast agent. Probably heard about that you can prepare these CT and MR scans using contrast agents. So for MR and CT, we use different kinds of contrast agents. For CT, the contrast agent we use is iodine-based. In MR, it's gadolinium-based. And why do we need a contrast agent? Here's an example on the left. You see a pre-contrast CT. And you can see that there is something on the right here in the hemisphere. It's not symmetric. There is something going on here, but you can't see clearly what. And on the other side, on the post-contrast T1 weighted, actually it's not T1. This is CT. This is a mistake here. So in the post-contrast CT scan, there is, like you can see that there is a brain tumor delineated by the contrast. And the same here with MRI. This is a pre-contrast T1 weighted image, and this is a post-contrast T1 weighted image. And you can see that something's going on here, and that contrast just delineates a tumor. So you can use a contrast agent to show blood-brain barrier disruption. And in many pathologies, the blood-brain barrier is disrupted. Normally, the contrast agent remains intravascular, but when there is blood-brain barrier disruption, then it goes into the tissue in case of tumors or infection or inflammation. So that's when you use a contrast agent. You don't need contrast agent when you want to exclude bleed, because, for example, in a CT scan, hemorrhage is also bright, and the contrast agent is also bright, so the contrast would mask the bleeding. So don't use contrast when there's a trauma patient. So yeah, trauma patient, no contrast. Stroke first line, you don't use contrast agent as well. And if you just want to see if the patient has hydrocephalus or the ventricles are big, you don't need contrast agent because you can see the ventricles without that. The other thing to know when you order a contrast CT or MR is the patient's renal function, because both iodine-based contrast agents and gadolinium get excreted by the kidney, and if the patient has a bad renal function, then then you don't order a contrast CT or MR, or you need to do some steps before that. And you have to know if the patient has iodine allergy or not. In CT, there are two types of normally, so you can use windowing to highlight specific structures on CT. And in a brain CT, there is a brain window and a bone window. The brain window is used to see the parenchyma better, detect hemorrhages. And the bone window is to see the sinuses and fractures. The other thing to know about CT is the images are acquired in the axial plane, and they can be reconstructed in various planes afterwards. So but the original image is always in the axial plane. You can do that in any plane. And actually, there's going to be it's going to be more interactive pretty soon after this theoretical part. So sorry if it's boring now. It will be more interesting probably later. Okay, and on the CT scan, when we describe things on a CT, we use words that refer to how dense the abnormality is in relation to the reference structures. And these reference structures include gray matter or white matter or whatever. So if something is dark on CT, that's called hypodense, like here up here. This is hypodense compared to the adjacent brain parenchyma. Isodense, we call it isodense when something is similar to something else, like it's the same. For example, this lesion here in the back is isodense to this cistern here. And this bleed here is hyperdense compared to the adjacent brain parenchyma. So how is density measured on CT? So radio density on CT is measured in Hounsfield units, and that ranges from -1000 to 1000. And by definition, 0 is water or CSF here, and bone is 1000, air is -1000, and white matter is between 20 to 30. Sometimes they ask you these values on exam, so probably you should know this list. Yeah, and density is quantitative, so it's always the same. You can compare it between patients. You know, it's a quantitative measure, and it depends on the attenuation coefficient. Okay, so when do we order a CT brain, or when do we use it? So normally we order a native CT brain in trauma patients when we want to see hemorrhage or fractures. Then this is the first line imaging for stroke, hydrocephalus, or when you want to show mass effect or midline shift or calcification. So here are some examples. This is a fracture here on the left. On image A, this is a big hemorrhage. You can see that pretty well on the CT. This hypodensity here on image B is a stroke here, like ischemia. C is hydrocephalus, like big ventricles. And calcification is hyperdense. It's like bone on CT. The advantages of CT are that it's really quick, few minutes, and it's readily available. And this is better, CT is better for bones. So when you want to see fractures, you do CT. The disadvantage is that there is radiation, and it's not as good for soft tissue as MR. Okay, so we kind of finished with CT. Let's move on to MR. So here are the sequences that you need to recognize for the exam. Except diffusion. Diffusion probably you don't need to recognize, but you need to know about it, and I'm going to talk about that later. But let's go through these sequences. So you need to know T1 weighted images, T2 weighted images, and flare. And T1 can come with contrast and without contrast. So how can you differentiate between them? So on T2 weighted images, the ventricles are bright, like here, like hyper intense. And so if you see like bright ventricles or bright CSF, that's a T2 weighted image in any part of the body. when the ventricles are dark, that can be T1 weighted image or flare. And T1 weighted image is the one which resembles the normal anatomy. So the gray matter is gray and the white matter is white. Okay, on a flare image, it's the other way around. White matter is gray and gray matter is white. Okay, so flare image is actually a T2 weighted image, but we null out the CSF signal. So it's the same image, just the CSF gets like nulled out. That's why it's like dark here. So if you see in a T2 weighted image, also the gray matter is white and the white matter is gray. Okay, and so we use T2 weighted images and flare to detect pathology. I'm going to show an example because normally pathology comes with edema and edema is bright on these sequences. T1 weighted image, so when there is contrast agent, you can tell that there's contrast agent, that the vessels are bright, like here. And you use post-contrast T1 weighted images to show pathology when these like things can enhance, like tumors. Diffusion imaging, you use it in stroke, and I'm going to talk about it a bit later. So on MRI, we talk about intensity, like not density, like in CT. So if something is bright, that's hyperintense, like here, this is edema, this is bright compared to the adjacent brain. The isointense is when something is similar to something else, like this tumor is isointense compared to the ventricle here. And hypointense is when something is dark compared to the, for example, white matter. This tumor is dark. Okay, so intensity, hypointense, isointense, hyperintense. We're gonna practice this later. So this is an example what I talked about, that T2 weighted imaging and flare is really good to detect pathology because most pathologies come with edema and edema is bright, and it really comes out, like, it's really easy to spot on these images, like the pathology. And blood is also hyper intense on flare images. Probably you don't need to know that part. Okay, so this is what you need to know about diffusion weighted imaging. So you need to know, we use it in stroke, and you need to know if there is diffusion restriction or not. So normally water molecules move between cells, and you can measure this diffusion with MRI. And when there is cytotoxic edema, the water molecules have less space to move, and we call this restricted diffusion. Like in cytotoxic edema, the cells are swollen, and yeah, that's when you see restricted diffusion in stroke, and this is really bright on these diffusion images, like down here. And when there is like vasogenic edema, there is more space between the cells, the water can move more freely, so we call that free diffusion. Did you understand this part? I hope yes. If you have questions, you can just ask right away, okay? You don't need to wait for the end. So what is MRI used for? Like we use it for tumor workup, stroke. In acute stroke, we don't use it routinely, but we could, because diffusion imaging is the modality that can detect like the ischemic or the earliest. So that's pretty good, but we don't use it routinely. We use CT. You can use it in epilepsy workup, demyelination, infection, chronic headache workup, cranial nerve palsy, dementia. The advantages are that there is no radiation, no ionizing radiation. It's really good for soft tissue contrast. You can customize the imaging technique to answer a specific question, and you can do the images directly in any plane. And you can also get functional information, not only structural. You can do fMRI to detect where, for example, the motor center in the brain is, or you can do perfusion imaging. The disadvantages are that it takes longer, and it's really, really expensive. So there is limited access, and the MRI bore is really, really tight. So many patients get claustrophobia, and they can't stand like lying there for a long time. And there are some absolute contraindications, like metal implants. If the patient has like aneurysm clips or pacemakers, or I don't know, like any implants from metal, that can be a problem in MRI. And even if the implant is MR compatible, then the metal makes a big artifact, so you don't really see the brain, for example, because of the artifact itself. And MR is not really good for bones. Okay, next. So, what should we order, a CT or an MR scan? When do you need which one? So normally, in an acute scenario, you order a CT scan, and that's like a native CT scan. And like, for example, in emergency department, when there is a trauma patient and you want to see hemorrhage or fracture, or if there is a stroke patient, then you order a CT scan. And probably they're gonna ask you this on the exam as well. For MRI, acute indication is rare. Normally you use MRI for tumor workup, epilepsy workup, sclerosis, like multiple sclerosis, and other stuff that I already mentioned. Okay, there is like a few words about vessels. I just wanted to list you this, just show you these different imaging modalities next to each other. Because for me, when I was a student, it was really difficult to differentiate. Like for me, these all look the same. But these are different methods, and it's nice if you know about them. So you can detect the vessels with ultrasound, with transcranial Doppler. And then you can do MR angiography. So this is like an MR angiography. You can do MR angiography with and without contrast as well. So in MRI, you can actually label the blood magnetically, and that can delineate the vessels themselves, so that you don't need a contrast for MR angiography necessarily. The third one is a CT angiography, and the fourth one is a digital subtraction angiography. Like you do it in the IR suit, and there is like a contrast agent injected directly in the vessels, and then you do fluoroscopy, and you can see the vessels like in real time. That's pretty cool, actually. When they put in stents or do coiling of aneurysms, they use this DSA. Oh yeah, and this is an important thing, that MR angiography is not equal with MRI with contrast. So MRI with contrast, we use it to detect like brain tumors or any blood-brain barrier disruption, but not the vessels. MRI angiography is to detect vessels, and you don't need a contrast agent for that necessarily. You can do this time of flight angiography that I talked about, when you label the blood magnetically, and that delineates the vessels, like here. Okay, done with that, and now this is your turn. So please, someone tell me what kind of imaging modality and what kind of sequence is on A, picture A. Anyone? You should know this by now. And there are going to be many quizzes during this presentation, actually. The second half of the presentation will be like quizzes. So someone please tell me what is number, like picture A. Or should I just call out to someone, or do you prefer to just answer by yourself?
Maybe it's an MRI?
Yes. It's an MRI, and which plane? Did you say coronal? Yes. Yes. And which sequence? Maybe that is a bit more difficult now because we just started to discuss that, but this is a flare, okay? A coronal flare MRI. Okay, B. What is B? That's easier.
CT.
Yes, which plane? Which plane?
Horizontal.
Yes, in anatomy, but in radiology we call this axial, but you are correct. What is C?
MRI.
Yes, and which sequence?
Surgical.
Which did you say, T1, T2, or flare? T1? Yes, it's T1. And which plane? Sagittal. I don't hear you really well, but I hope you said sagittal. Okay. Okay, cool. Well done. And what is D? MRI or CTs, number D or D? Anyone? Okay, it's a T2 weighted MR scan. Axial plane. What is E? Someone? Axial plane, yes. I didn't hear you. But this is a post-contrast T1 weighted MR scan. And here are the answers, actually. So, yeah, you were good. Well done. There are going to be more questions, so please, someone, please be more proactive. So, because these cases are going to be on the exam as well, like really similar ones. So we're just going to practice this. So that's not going to be the first time you see this. So there's a 85-year-old male on warfarin, had a ground level fall at home. He hit his head. There is a bleeding wound on his head and he's confused. Blood pressure is 130/80, heart rate is 70, saturation is 91. Which of the following exams will you order? So first you need to know what do you order normally in this scenario, and then you need to recognize the correct picture. So which one is the answer and why? Can someone tell me?
If it's acute, then CT.
Yes. And which one is that one? Among A, B, C, or D is a CT.
B.
What did you say?
B.
B, yeah, correct. Yeah, so answer is B. Okay, next one. 30-year-old male presents with a sudden onset severe headache. Describes it as his worst headache of his life. Blood pressure is 130/80, heart rate 75, saturation 94. Which of the following exams will you order?
I think it's bleeding, so A.
What did you say, B or A? What?
A. I think it's a bleeding.
Okay, yes, yeah, it's correct. It's a bleeding. We think about subarachnoidal bleeding, but actually your answer was correct, but not as a. So if you want to see the bleed itself, then you order B. B is like the native CT, so you would see the bleeding here. Your answer is correct. I didn't think about that. That the next step, if the bleeding is because of aneurysm rupture, we're going to talk about it a bit later, then the next step is that you need to detect the aneurysm itself, and then you order a CT angiography, and that's A. But first step, you order B. I didn't know it was that tricky, so probably I will change this. So A is a CT angiography, B is a CT scan, C is a post-contrast MRI, and D is a T1 weighted pre-contrast MRI. Okay, cool. Next, 60-year-old female presents to the ED after a motor vehicle accident. She hit her head, blood pressure 125/80, heart rate 88, saturation 93, Glasgow's coma scale 14. Which of the following exam will you order? I guess it will be pretty easy by now. Anyone?
D.
B, D, did you say D?
Yes.
Okay, yeah, so CT scan again, and D is a CT scan because it's a motor vehicle accident, hit her head. We think about bleeding, and you need a CT scan to detect bleeding, like a native CT scan, and that's D. Yeah, correct. Okay, anatomy. I'm not going to teach you anatomy because you already learned it. Here are some links where you can review anatomy on MR and CT scans. And we are going to review anatomy with a quiz again. Sorry, guys. So again, your turn. So what is number A?
Lateral ventricle.
Yeah, correct.
Lateral ventricle.
Yeah, correct. B. Actually, this is actually the lateral ventricle posterior horn, but the choroid plexus is in there. That's why that bright thing is in there. C. This one. What do you say?
Maybe.
The what?
Third ventricle, maybe.
Yep, correct. D. I guess I'm gonna tell you that one because that's a bit more difficult. So that's the foramen of Monroe. The hole between the lateral ventricle and the third ventricle. E. This. What's that?
Corpus callosum.
Yeah, corpus callosum, the genu part. F.
Cardiac nucleus.
Yes. G. Kind of here.
Lenticular. Lenticle.
Yeah, you're correct. So this is the putamen, actually. But that's, yeah, the basal ganglia, lenticulate nucleus. Yeah, you're correct. G. H. H you can't see pretty well. I don't know why I put this here, but I wanted to show you the capsule, the internal capsule. But yeah, H. I.
اینو میخواستم بگم
What did you say? Sorry, did you say something? Okay. What is I? The I is the thalamus. I. J.
Insula, maybe.
Yes. Yes, and K is the fornix. I just tell you. And L is the quadrigeminate cistern. So yeah, that's it for CT scan. Just one slice. There is an MR scan, like a sagittal T1 weighted image. Again, your turn. What is A? This is easier. A.
Corpus callosum.
Yes. B.
Thalamus.
Third ventricle.
Yeah, third ventricle. Yes. C.
Singular gyrus.
The singular gyrus. D is the septum pellucidum. E. The fornix, you said?
Fornix.
Okay. F. F.
Quadrigeminal plate.
Yes, correct. G. This whole thing.
Cerebellum.
Yes. H.
Fourth ventricle.
Yes. I.
Cisterna magna.
The cisterna magna. Yes.
Cisterna magna.
Yes. J.
Brainstem.
Yes. It's a brainstem. K.
Pons.
Pons. Yes. L.
Inferior claviculus.
Yes. The aqueduct. Yes. Is there anything? Oh yeah. M. This is the pituitary gland. N is the corpus mammillaris. O. Someone. O.
Spinal cord.
What do you say?
spinal cord.
This is the spinal cord. I didn't hear you well, but I don't know why I don't hear you well. But anyways, this is the spinal cord. Yeah, well done. I think you're pretty good at anatomy, so nice. A, again.
Caudate necrosis.
Yes, yes. B. This. Yes. C.
Insula.
Yes. D. Yeah, insula. D. Thalamus. Yeah. E.
Inferior corner lateral edge.
Yeah. F. Corpus.
Corpus callosum.
Yes. And G.
Cranium of corpus callosum.
Yes. H.
Anterior horn of lateral edge.
Yes. I. That's the globus pallidus. And the J. That's the third ventricle. Okay. But well done. You're really good again in anatomy. Yeah. Learn it really well. And then there's another MR scan. This is like a lower section. And I think I'm going to tell you the structures that just to speed up things. Okay. So A is the optic nerve. B is the internal carotid artery on the right and on the left. C is the pons. D is the fourth ventricle. E is the temporal lobe. F, basilar artery. G, this is like the inner auditory meatus. So you can see the inner ear here. H is the cerebellum. Okay, and circle of Willis. So let's name the vessels. Which vessel is number A? Or should I help you a little bit? Okay, I'm gonna help you. So the blood comes in from here. So this is the internal carotid artery, okay? C is the internal carotid. So this is anterior, this is posterior, okay? So what is this? Does anyone know? So internal carotid artery comes in here. Yes. Yes, the anterior cerebral artery.
Yes.
Yeah, anterior cerebral artery is an A. What is B?
Middle cerebral artery.
Yes, correct. The middle cerebral artery. And then D, what is D? These are the vertebral arteries, and then they join, and it becomes the basilar artery. And then what is F? F is the posterior cerebral. Yes. So yeah, basilar artery, the posterior cerebral artery goes like here, and then this is the posterior communicating artery, and it connects to the the anterior circulation. Okay, that's it. This could be on the exam as well. So we finished with the basic concept part, and we're going to talk about the pathologies now. So first big topic is hemorrhages, and you need to differentiate these four types of hemorrhages from each other on CT scans or on images. And we're going to practice this as well in the end, so pay attention. So one is the epidural bleed, subdural bleed, subarachnoidal bleed, and parenchymal bleed. And you can see on this picture like nicely how they differentiate from each other, but we're going to discuss them like one by one. Let's start with epidural hematoma. So epidural hematoma is located between the skull and the dura mater. And usually it's caused by traumatic brain injury. And there is like a fracture on the skull, for example, here, and the middle meningeal artery gets injured. And this is an arterial bleed. That's why it's progressing really rapidly. You can see this bleed here. It's like lens-shaped, doesn't cross sutures. And it requires really emergent neurosurgical consultation because they need to stop the bleed and evacuate it. Otherwise, the patient will like die because the bleeding will expand and compress the brain. So this is emergent stuff. And when you see this lens shape thing on the CT scan, that's epidural hematoma. Okay. Next, bleed. Oh, sorry, I just heard myself back from someone's mic. I don't know what happened. The second type of bleed is subdural hematoma. It's located between the dura mater and the pia mater, and this is a crescent shape. It crosses the sutures but doesn't cross the midline, and this is like more. It's expanding more slowly because it's a venous bleeding. It's caused because of injury to a bridging vein. Bridging veins are the veins connecting the cortical surface and the dural sinuses, and they cross the subdural space. And then when they get torn, then there is the subdural hematoma. And it can be caused by trauma as well. All kinds of bleeds can be caused by trauma, okay, any of them. But it's really typical in old patients when the brain gets atrophied, or there is like brain atrophy, and the brain shrinks and these bridging veins get pulled and then they just tear more easily. And the typical scenario when there is like an anticoagulated patient hit his head, like old patient in a nursing home, falls out of the bed and hits his head, and then there is like a subdural hematoma. Yeah, so it looks like this here on the left side on the CT scan. Third type of bleed is the subarachnoid hemorrhage. This is also it can be caused by trauma as well, but the cause can be aneurysm rupture. This is when I talked to you about this young patient, sudden onset of severe headache, worst headache of patient's life. That's like these are the typical symptoms for aneurysm rupture. When there is an aneurysm rupture, normally the blood is located on the base, somewhere like in the basilar cisterns. When the blood is more on the convexities, then probably it's because of trauma. Subarachnoidal bleed is located between the arachnoidea and the brain, and it goes within, like inside the sulci. So when you see this irregular pattern here, it goes like inside the sulci between the gyri. That's subarachnoid hemorrhage. And when you see blood in the basilar cistern and you suspect like an aneurysm rupture, then the next step is what we already discussed, that you order a CT angiogram to check for the aneurysm itself. Okay. Then parenchymal hemorrhage is the fourth time, and this can be caused by a number of different etiologies. So parenchymal hemorrhage is just basically blood within the brain parenchyma. So the first example here is a contusion, like patient hit the head and there is like a contusion bleed here. This is here like low platelets, like bleed because of low platelets. Then the third one, this is like a hemorrhagic tumor. And the fourth one is like bleed in the basal ganglia because of high blood pressure. And the basal ganglia is a really typical location for like bleeds because of high blood pressure. Normally in older patients. When you see basal ganglia bleeding in young patients, what do you think about? Because young patients normally don't really have high blood pressure. So it's possible that they consume cocaine actually, because that can cause high blood pressure. Okay. Another thing to know, probably for the exam, that blood doesn't look the same all the time on the CT. Like it changes its density while the time is progressing. So acute blood is hyperdense, like here. Subacute blood gets like isodense compared to gray matter, and chronic blood it gets like darker or more hypodense. Okay. Nice. So we're gonna practice this a little bit, and I think accidentally my mic is plugged in. Try. Do you hear me now as well? Because I think I hear you better if you talk now. So what kind of bleeds do you see on this picture? Here is like a brain trauma. There is swelling in the soft tissue here. There is a fracture on the skull. What kind of bleed is this one? Anyone can tell me? Can you tell me again? Yes, subarachnoidal bleed here. And this tiny thing is like contusion here, like intraparenchymal bleed. And what is this one? Can anyone tell? This one and this one. What type of bleeding is this?
Can you show it again?
Which?
Could you show it again?
What did you say?
Epidural?
No, epidural was this lens shape, and this is more like crescent shape. So I would say that this is actually subdural bleed. Okay, next one. So we're gonna talk about stroke. Just give me 1 second because I want to check if I could download the attendance list correctly. Oh yeah, I downloaded it like 12 times. Okay, cool. Anyways, stroke territories. So when they show you a picture like here in the middle, you need to know which large vessel is occluded by looking at the territory. The anterior cerebral artery, it supplies like the medial surface of the brain and just a little part of the convexity as well. This is a schematic picture, and this here is a left-sided anterior cerebral artery occlusion stroke. Just a reminder, this is the anterior cerebral artery. This is the middle cerebral artery, and this is like an MCA stroke, middle cerebral artery stroke here. The middle cerebral artery supplies the majority of the convexity of the brain. And this is a posterior cerebral artery stroke on the left side here. This is the posterior cerebral artery, and it supplies the occipital lobes and the lower part of the temporal lobes. Okay, so if you see this big one here, that's a posterior cerebral artery stroke. On the exam, probably they will show you really obvious cases, not like a tiny thingy, just like here, it's like obvious big thingy here. Okay. If it's not obvious, please let me know, and we can practice. And this probably you don't need to know. I just wanted to show you, like, it's interesting that even you can tell, like, even when smaller branches occlude, they can have a specific pattern on imaging. These are diffusion weighted images, and just nice that you can like tell which vessel occluded by just looking at the image. Okay, and so what do you do when there is an acute stroke patient coming in? First step in imaging is that you order a CT brain, a native CT brain. You start without contrast, and then you see a hypodensity like here. You can see this area here is darker than here. It's asymmetric. And the other thing we can see is that there is this here in the middle, this we call hyperdense media sign. And this is the middle cerebral artery here, and there is the thrombus itself sitting in there, and it's like bright here. And it is the same patient here on the right. You can order a CT angiography if you suspect a large vessel occlusion, because then they will perform thrombectomy, and then they need to see where the thrombus is. And on this picture here, in the CT angio here, you can see the filling defect. Like there is a part missing here, and that's where the thrombus is. So what's the therapy for stroke? So if there is a large vessel occlusion, like middle cerebral artery or something like big, what they can actually take out intravascularly, like with interventional radiology, then they do thrombectomy. And if the patient is within the window, like if there is the time from the onset of the symptoms is less than 6 hours, then they can do thrombectomy. But there are some newer protocols which allow you to do thrombectomy 24 hours after the onset of the stroke symptoms. If they don't see a large vessel occlusion, but they see this hypodensity, there's a stroke patient, but probably that's like a smaller vessel, or they don't find like a large vessel occlusion. And if the patient has no contraindication, the neurologist can do thrombolysis if the patient is within the 4-hour window from the onset of the symptoms. Oh, the other reason why you order a CT brain like without contrast, is to exclude bleeding. That's important. I forgot to tell you that. So if there is a bleeding on the CT scan and a stroke, but bleeding is a contraindication for thrombolysis, so they will not thrombolyze the patient. Okay, so one reason is to detect the stroke itself, other reason is to exclude bleeding. Okay, and the role of MRI in acute stroke. So this is where you need to know a little bit about diffusion imaging. As I talked about, as I mentioned, diffusion MRI can show you the infarcted area with the cytotoxic edema, and that part is already irreversibly injured, so that cannot be saved. That's already dead. And if you perform MR perfusion as well, MR perfusion can show you the whole area in the brain which is hypoperfused, including the region which can be saved and including the region which cannot be saved. And the difference between the two is called perfusion-diffusion mismatch. And this area between these two lines, and this is the area what you can actually save with therapy, and that's called a penumbra. And in some centers they perform this before treating the patient, so they can actually know if it's worth to treat the patient or it's already too late and it will not help at all. Okay, so the penumbra shows you the region with reversible injury, and I saw questions like this in the exam. Okay, next disease, aneurysms. I talked about this a little bit. So the aneurysms in the brain normally occurs in the junctions, most commonly the anterior cerebral artery and anterior communicating artery junction. It can happen where the middle cerebral artery branches off, and it's typical also in the basilar tip. And it can rupture if it reaches a certain size or it has a certain morphology, and it can cause subarachnoid hemorrhage. So that's a problem. So you can actually treat aneurysm if it's like seems to be dangerous or big enough. And the treatment is normally endovascular. You can coil it, or you can do open surgery and clip it. That's more rare nowadays. And there are some examples. They are not like super huge aneurysms, but here, this little bump on this CT angiography, that's an aneurysm. This is an MR angiography, and this bump here in the middle cerebral artery branch, where it branches off, that's an aneurysm. And the same thing here on the 3D reconstructed images, this is the aneurysm, this bump here. And this is a DSA, and this is an aneurysm again here. Okay. This is also the anterior cerebral artery. Like this location equals this location, okay? This is the carotid artery, internal carotid artery. This is the middle cerebral artery. This is the anterior cerebral artery. Okay, and this is the anterior communicating artery here. Okay. And other pathologies, these are not like super important for the exam. Like you don't, brain tumors, for example, you don't need to name the histological subtype because that's already difficult for like a neuroradiologist itself as well, but you need to know some basic concepts. So if on the exam they show you like multiple tumors, that's probably in the brain, that's probably metastasis. The most common brain tumor is like metastasis. Then among the primary brain tumors, the most common is glioma, are actually, oh, I thought it was gliomas. Okay, it says meningioma. Okay, weird. Okay, don't learn this. In adults, brain tumors are mostly supratentorial. In pediatric population, it's mostly infratentorial. There are specific tumors in the cerebellopontine angle, like meningiomas, schwannomas, epidermoid cyst. This is a glioma picture here. It's a typical picture with ring enhancement, necrotic core, edema. What you need to know about tumor is that if there is a tumor suspicion, you order contrast imaging, like contrast CT or contrast MR. The workup is normally MRI with contrast, okay? So contrast agent, contrast agent, contrast agent, because it can show you the blood-brain barrier disruption and the enhancement. Okay, other pathologies, trauma. We already talked about hemorrhages, but you need to know about herniations. When there is a big bleeding or brain swelling or anything going on in the brain, then it compresses the brain parenchyma, and these herniations can occur, and that's bad. That's a problem. First type is the singular herniation, when the singular gyrus herniates below the falx cerebri. The second type is the ankle, oh, that sounds weird, herniation, when the uncus herniates through the incisura tentori, and an important symptom is anisocoria, when one of the pupils is bigger than the other, because the uncus compresses the oculomotor nerve, which it's cranial nerve number 3. It goes somewhere here in the brain, and it gets compressed. And the third type of herniation is pretty bad. That's when the cerebellar tonsil goes through the foramen magnum, and the problem is that it compresses the brainstem, and all these the vegetative, all this breathing center is in there, so the patient actually dies when this happens. So you need to know about these. Okay, and I'm gonna just show you some other pathologies. These are not that important, but it's important that you actually saw them, or you know how they look like. You have an idea how they look like. So sclerosis multiplex, multiple sclerosis. There are white matter, the demyelination plaques in the brain. These lesions normally located commonly around the ventricle. These images are flare images. This is the sagittal flare, and you can see these demyelinating areas as hyperintensities, and we call these 1,000 fingers when you see this here, like little fingers around the ventricle in the sagittal image. And these are the same lesions here on the axial image. On the right side, you can see herpes encephalitis. It's really bad. It's an acute condition. It affects the temporal lobe, and it's like a huge hyperintense area in the temporal lobe on T2 weighted images. Abscesses. And this image, this looks like a glioblastoma, what I showed you before, ring enhancing lesion. But abscesses, they have this pus inside, and it's really thick, and it restricts diffusion. And this is how you can differentiate from brain tumors, like with diffusion imaging. I don't think you need to know this. Other pathologies that you can see nicely with MRI is atrophy or hydrocephalus. This is a normal brain. This is an Alzheimer patient brain. And ventricles got bigger because the brain parenchyma shrinked, and you can see that the gyri are smaller and the sulci are wider. And there are some thoughts about hydrocephalus. When you see large ventricles, that's when you call this hydrocephalus. There is just a reminder about how CSF is moving in the brain. So it's produced in the lateral ventricles, and then it goes through the foramen of Monro to the third ventricle, then the cerebral aqueduct, fourth ventricle, and then it exits through the foramen of Magendie and Luschka, and then it gets absorbed in the cerebral, arachnoid granules. And then there are two types of hydrocephalus. There is obstructive, we call this non-communicating hydrocephalus, and communicating hydrocephalus. When there's an obstruction anywhere in the ventricles, like for example in the cerebral aqueduct because of a brain tumor, then all the ventricles before the occlusion gets large, they enlarge, and everything after, later on the pathway, they don't enlarge. So that's when we call this obstructive hydrocephalus. Communicating hydrocephalus can happen when there is an overproduction of the CSF, for example, plexus choroideus tumors, or there is reduced absorption because of a subarachnoidal bleed, because the arachnoid granules get clogged, or if there is meningitis. And there is a special type called normal pressure hydrocephalus. This is idiopathic, and all the ventricles are enlarged, but there is no obstruction. And those are in old patients with dementia, urinary incontinence, and gait disturbances. I was not sure, but it's gonna be only 2 slides or 3. They told me to talk about neuro. Did anyone else talk about the spine yet, or will someone? Or is there another day when they are supposed to talk about this? I'm not sure, but these are only 3 slides or few slides. So I'm gonna just finish with that, and we are almost done. Yeah, I was quick. So for imaging the spine, there are 4 different modalities. No, actually 3 modalities that we use. One is X-ray on the first image. Second one is CT, and the third one is MRI. And okay, this is basically the same. If you just want to see a disc protrusion or trauma, then you don't need contrast agent. And for tumors, infection, myelopathy, or post-op patients, you can give contrast agent. Who is talking, or did you hear what's going on, or what? I am not sure what was going on. I thought you guys, no one talked. Okay, I'm not sure what's going on. Anyways, spine imaging modalities. Okay, so here are some indications, advantages and disadvantages. For trauma patients, you can use X-ray or CT. X-rays you can use intraoperatively in the operating OR suite because they are portable. Then MR, you can use it to detect radiculopathy when like a exiting nerve is compressed by like a disc herniation or something. For brain tumor, not brain tumors, like spinal tumors, myelopathy. The advantage of X-ray is that it's inexpensive, it's widely available, it's quick and portable, and CT is also quick, widely available. It's really good for bony structures. The problem with X-ray is that like it's difficult to interpret because it's like one plane and everything is like gets overlaid on each other, and it's hard to see sometimes what's going on. There's radiation exposure with X-ray and CT as well. CT is more expensive, but better than X-ray to see actually what's going on, but it's not really good for soft tissue. For soft tissue, MRI is the best. You can see the relationship of disc to nerves. So if there's a disc herniation, you can see if it's close to an exiting nerve, and you can actually find the cause of like a back pain. There is no radiation exposure, but it's really expensive, not widely available. It's a problem when a patient is claustrophobic, and I already talked about these contraindications like metal implants. So it's the same for the spine, like in the brain, except that in the brain we don't really use X-ray at all. Okay, and for the exam, you need to know about, this is on the list of images, I don't know why, but you need to recognize spinal cord compression. So let's start with the right side here, meningioma. This is really obvious. Here there is like a spinal cord, like an interspinal meningioma compressing the spinal cord here. And this is not a cord compression, but I just wanted to show you like a typical disc herniation because this is really common. So here are the normal discs, and here, bump here in the back, you can see that it's like protruding, and it doesn't compress the spinal cord because the spinal cord ends up here, somewhere here. So this is the cauda we know already. Okay, so a few more practice cases for the end of the presentation. So what kind of hemorrhage is this? Again, someone can tell me. Epidural, subdural, subarachnoidal, or parenchymal?
Subdural?
Yes, correct. This is a subdural hemorrhage on the left side on native brain CT. Correct. Well done. Next one. What kind of hemorrhage is this one?
Epidural.
Yeah, correct. This is an epidural hemorrhage on the right side on this native brain CT. This is a patient, like a kid. I will help you a little bit. This is here. This is the hemorrhage itself. So what kind of hemorrhage is this one? Can you repeat this?
Parenchymal. Parenchymal.
Yes, correct. Parenchymal. Yeah. This one here.
Subarachnoidal.
Yes, correct. Subarachnoidal, and it also breaks into the ventricles as well. But it's subarachnoidal. Yes. This one here.
Epidural.
Epidural, yes, correct. Like lens-shaped. Oh yeah, some of the pictures were not from our department. I stole them from here. This is a really nice website. And thank you for your attention. So I hope it helped a little bit for the exam. And if you have any questions, please let me know.
Thank you. Have a nice day.
Thank you. Have a nice day.
Have a nice day.
No questions.